everybody. Welcome. This is Dr. Neel Shah, who is an orthopedic spine surgeon, specializing in minimally invasive spine surgery. So, Dr. Shah is on staff at NYU and is in private practice at New York Center for Spinal Disorders, with locations on the Upper East Side and in Flatiron. So, welcome, Dr. Shah.
Thanks for having me.
Yeah, and I am Matthew Rome. I'm the founder of Equilibrium Physical Therapy. We're kind of more like a boutique orthopedic physical therapy practice on the Upper East Side. And today we're going to talk about minimally invasive disc replacement surgery of the cervical spine. And we've talked about the differences between cervical spine and fusion. We have a couple other videos we've done with Dr. Shah. So we talked about primarily differences and benefits of cervical disc replacement versus cervical fusion. We talked about the actual procedure itself, what's done surgically and operatively. So you can check out those videos. But today we're going to talk about the rehab guidelines. So what are some post-operative precautions? What are some post-operative recommendations, rehab guidelines? And we'll talk about it a little bit from a surgical perspective and then also from a physical therapy perspective. So, Dr. Shah, take it away.
Thanks for having me, Matt. This is a really interesting topic. I actually love talking about it, being an orthopedic surgeon. I'm about 10 years into practice now. And I've seen, I like to equate cervical disc replacement kind of to what hips and knees were. And it's really funny, I think you're about the same age as me, so you probably saw this too. When we used to do total knee replacements, we would wait to move their knee until their incision was healed, which, looking back now, that seems like that was, horrible. Like, why would we do that? Like nowadays, patients are moving their knees the day after surgery. And I think my protocol for disc replacement has evolved similarly. When I first started doing them, I was very like, oh my God, we can't move you until they're like healed and all this. And now it's great. Now I tell them to start moving their neck the day of surgery. And so, typical timeline in terms of recovery from a disc replacement. You do the surgery, it takes about 3 hours to do two-level disc replacement. That's all in terms of anesthesia, waking up, all that. When the patient wakes up, they usually wake up in a soft collar, one of those foam collars. That's really just for comfort. I joke with my patients, if I see them wearing a collar at their first post-op, I'm going to yell at them. And for the first, I'd say, 2 to 4 weeks, you're really just walking a lot to really get that cardiovascular health back, get the anesthesia out of your system. You're really rapidly weaning down on opioids. I'd say most patients in my hands take opioids, for 3 or 4 days after surgery, and they transition over to an Advil or a Tylenol. But really, you're doing some gentle range of motion exercises a couple times a day, moving your neck forward, back, left, right, and a little bit of turning. And you're slowly getting back into activities of daily living and just really limiting your heavy lifting. I tell my patients, you're really not going to mess up the work that we do by doing anything too crazy. You're just going to kind of flare up the inflammation. Just like anything else, when we do surgery, your body ramps up an inflammatory process. That process usually takes somewhere between 48 and 72 hours to peak, but then you have to come down the hill. So if you're a little too active, a little too quickly, you're just gonna keep pushing that inflammation up, and it's just gonna take longer for it to kind of come down. And it's almost like kicking the can down the road. And then after the first 4 weeks, really start some formal physical therapy between 2 and 4 weeks. And a lot of, I think, for disc replacement in my hands, I'd love to hear from you, is really working on, the disease of the 21st century, which is all of us are like this, looking at our laptops, our cell phones, and all that, and really rebuilding our posture so that this doesn't happen again. And then, if you have any deficits in terms of range of motion or weakness in the arms from the compressed nerves, kind of getting those to start working again as well.
Yeah, totally. Love that. And yeah, we typically do see these in ranges. Some surgeons like to send to physical therapy right away with a little bit more precautions, like, because, you want to make sure that we're guiding, pain-free movement. I think that's the one thing, like the whole no pain, no gain thing that doesn't fly in physical therapy anymore, whether it's for a knee, a shoulder, or a spine, like you want to use pain as your guide. So, but you are free to move your neck. That's the whole point of a cervical replacement is that we want motion preservation, right? So we want to encourage mobility. So some of the things we work on really early is not necessarily messing with the actual neck, right? We're looking at all the compensatory issues. Patients are stiff. Patients have tension in their upper traps, scalenes, rhomboids. Maybe you just need to do some work on the neck, shoulder, and just some light tissue work just to because of all the guarding, and then just start working on like thoracic thoracic opener exercises, postural exercises, where again we're reducing we're working on the primary thing that was offensive in the first place, which is this kyphotic upper cross posture, where with rounded shoulders, forward head, we want to do, opening up the thoracic spine, opening up the chest. And one of the reasons why we get so much, disease at C5, C6 is what we've been talking about, is that those are the most mobile segments. They get the most activity, and therefore the most degradation. Uh, but there's ways you can work on your body mechanics and your thoracic spine and your posture to reduce the load on those specific joints. And then we'll talk about the strengthening process of the neck, which we can get into. That's more about I would say I'll leave this to Dr. Shaw. When do you typically recommend starting to really strengthen anterior neck flexors, suboccipitals? Because, right, we want to work on longus colli, longus capitis, splenius muscles in the back, like really work on the local stabilizers. And just to kind of, before you answer that, say, for our public, we have local stabilizers, which are these small segmental muscles that attach segment to segment in close to your spine. Then we have your more global movers, which are, your big, powerful muscles like your SCM, your sternocleidomastoid, and like these other big muscles that are kind of taking over that really shouldn't. We have to encourage strength of stability of your local stabilizers. When do you like to green light that?
It's a great question. As I open up my posture, because I'm noticing I'm slouching as well. So that's a great question. Again, it goes back to the inflammation part. The smaller stabilizers, we're working more closely to. We do have to, take the longest coli off the bone a little bit. So I do want it to kind of scar back down. And that's why I usually will tell people or my patients, and when I speak to the physical therapist as well, hey, listen, like, for the first 6 weeks, really work on what you said, like getting some of the pain to go away, getting some of the tension or the knots to get out. And then at the 6 week mark, I think a lot of the muscles have kind of, the inflammation's gone down, they've scarred down if they need to. And at 6 weeks, I tell them to really start progressively starting to strengthen those again, right? You're not going to go back to like full activity, but week by week, increase the amount of weights or the amount of stress or strengthening you're doing at that point.
Yeah, it's great. And there's ways to really progress it and teach it. We teach anterior neck flexor strengthening, where we do these chin tucks. If you're lying down on a back, you chin tuck and you just start to engage those muscles. Then eventually you can be lying down where you tuck and you lift against gravity and you hold for different durations of time. So there's ways to really strengthen these muscles. And the way that we encourage is, like, everybody knows that the core is really important to prevent low back and to manage low back pain, right? Your transverse abdominis, your big core muscles, not the glamour abs, not the big rectus muscles, but the deep core muscles are what we use
Yeah.
to treat the low back. We have the same thing going on in the neck. These deep stabilizers in the neck are supporting your spine. So it's really important to strengthen. We call it the core of the spine. And so, yeah, once we get the green light from your doctor, and you could, make sure you always talk to your surgeon and talk to your physical therapist. So your physical therapist communicates with the surgeon as well, when they really feel comfortable green lighting just a slow progression of activation of those muscles, and then of course really progressing the strength. And then once you get that strength up, then you can start doing more functional things, right? Like everything in physical therapy needs to be functional. So once Dr. Shah does his job and replaces the disease process, you got to build up the strength, and then you got to relate that into functional tasks, whether that's cooking, cleaning, or it's really aggressive sports specific behavior, right?
Yeah, usually, and I'll let patients depend, like you said, and I really like to tailor what I do to the patient. I don't have a specific formula for everyone or an algorithm for everyone. I'd like to tailor, take into account what they do. If they're a high-level athlete, do they just sit in front of the computer all day? It really changes what you're going to do and how aggressive you're going to be about things. But the rule of thumb is, as long as they're not in a very high contact sport, I let them go back to most normal activities. I essentially cut the cord at 6 weeks and tell them, hey, listen, you can do whatever you want, but get back to what you used to do in a slow manner, kind of a stepwise graded manner, and work with your physical therapist, come up with a plan. If they're a football player, hockey player, some sort of high impact activity, I do like to wait to 12 weeks to allow a better osseous integration. So that's where the bone kind of grows into the metal, to give that a little bit more time.
Yeah, it's a really good point. So again, talk to your surgeon, talk to your clinician, your physical therapist, like find out what your goals are, because sometimes post-operative rehab guidelines are different depending on whether what you're trying to get back into, contact sports versus non-contact, just regular activities of daily living. But generally, let's see my dog jumping down there. Generally, just to have a general start, like a start green light. Date for is really good right when you get discharged. Like ask your doctor, like, when can I start doing this? When can I start doing that? When can I start physical therapy? When can I start strengthening? And I think the one thing that people kind of shy away from physical therapy is that they think that when they get referred to physical therapy, we're jumping right into really strengthening and stabilizing the neck, which there's so many other things to focus on, which is why we really encourage very early physical therapy. And sometimes it's up to the physical therapist to talk to the doctor and say, hey, trust me, I got this. I'm not going to mess up your patient, because I think that's important. There's a lot of physical therapists out there and there's a lot of doctors out there, unless they communicate and trust each other. I think a lot of times physical therapists don't see those referrals till much later down the line. But if physical therapists can have the trust of the doctor saying, okay, I know how to handle this rehab process. I'm going to listen to. I'm not going to start the strengthening process until 4 weeks or 6 weeks. I'm not going to start aggressive mobility. I'm not going to do aggressive manual work. Really, just focusing on more of like this general mobility, postural work, thoracic openers, and just general mobility uh, before get into the heavier stuff.
Yeah, I agree. I think that's a great point, right? Like physical therapy isn't just like go work out. There's a lot of other things you can do and a lot of things you should do before you really get to the heavy lifting. And I think having a surgeon and a physical therapist on the same page is ideal. And f trying to find a surgeon or and a physical therapist that are willing and open to communicate is huge, especially for patients who want to get back to what they were doing pre-injury. And that's always my goal is. I don't want spine surgery to be inhibiting to your life. I want you to get back to the things you want to do after we kind of get over this like a road bump or a speed bump in the way.
Yeah, love that. Well, I think that's great. Any other like closing thoughts on rehab guidelines? I think pretty much covered a lot of it, right?
Yeah, I think I think they're evolving. I think we're learning more as time goes on. But I think what we talked about is kind of the standard at this point. I think we've gotten a lot more aggressive with disc replacement and how to recover with them, and I think patients are really reaping the benefits of it.
Yeah, great. And we always recommend, from a physical therapy perspective, my practice is like more of a one-on-one practice. So, there's questions we're going to do our next video, like what to ask a physical therapist, what to ask a surgeon. Part of those things is like, how do you find a physical therapist that's going to communicate with your surgeon? How are you going to get that really personal attention on both ends? So we'll talk about that in another video. But Dr. Shah, thank you so much for chatting with us today. We'll have your info below. But again, New York Center for Spinal Diseases. You got a spot on Upper East Side and a Flatiron. Really, Dr. Shah has tons of experience in minimally invasive spine. Watch some of the other videos about the surgical procedure itself, and then also some of the indications to differentiate when you do a fusion versus a disc replacement. But it was a pleasure having you today.
Thanks for having me.
Yeah, thanks so much. All right, we'll talk soon.
Take care.
All right, bye-bye.